Yes, just a quick nod whether I am visible and audible so that I can start my session. I'm so glad to see you all here Sunday morning. Yes guys, am I visible and audible so that I can start my session? Thanks Ankita for the nod. So for today's session, okay, we will start where we had to stop our yesterday's session, so we will begin from there. We'll continue from there. Okay, very important topics. All of them are very, very important. Okay. Yes. So we have seen this question already yesterday. For those who were not there yesterday, answer to this, that is, all are true about radial nerve except. Okay, we have already seen this. Yes, good morning everyone, a very happy morning. Kaushik, is it better now? Yes, we have seen this yesterday. The answer to this is it is not a continuation of lateral cord. We know that radial nerve, we said that it is the nerve of the extensor compartment, that is the posterior compartment. That is why it is the continuation of the posterior cord of brachial plexus. Okay, and the root value is C5 to T1. That means the entire brachial plexus. Yes, it is damaged in the fracture shaft of humerus because it is there in the spiral groove which is there in the shaft of the humerus. And we also said that it causes wrist drop. We had seen the mnemonic Dr. Kuma. So wrist drop is seen in radial nerve. So that dropped wrist, we want to take it up. That is why we use cock-up splint. Correct? That is why we use cock-up splint. Correct? Tell me, which is the largest nerve of the brachial plexus? Which is the largest branch of the brachial plexus? Which nerve? It is the radial nerve. It is the radial nerve which is the largest branch. Majority of you are answering it median. The answer is radial nerve. Remember that. We have seen this image as well, that this is your image which is showing Saturday night palsy. Saturday night palsy or your crutch palsy, because that is how we use the crutch. So this will damage your radial nerve. Okay. This will damage the radial nerve. So Saturday night palsy or crutch palsy is radial nerve, and we have also seen that the radial nerve palsy leads to wrist drop. Okay, it is very logical that how does radial nerve palsy leads to wrist drop, because radial nerve here, it is on the extensor or the posterior compartment, and if it is paralyzed there will be no extension at the wrist, and that is why there will be a wrist drop. Okay, so because if this nerve is affected, no extension, so there will be wrist drop. To take that wrist up, we will do cock-up splint. So cock-up splint is used for radial nerve. Okay. Also, you can see here that this is the fracture shaft of humerus. This is the fracture shaft of humerus. You have the spiral groove here, which has the radial nerve, and that is why in fracture shaft of humerus, you will see paralysis of radial nerve. Correct? Just let me ask you here. Let me ask you here, what is this part? If they ask you to identify anatomically, what is this? Identify this. What is this? Very good, Saurabh. This is your coracoid process. This is the coracoid process. And what is this? Is it clavicle? Is it coracoid process? Is it acromion process? Is it glenoid cavity? What is this? Yes, very good. This is your acromion process. Okay, that's your acromion process. Coracoid process is what type of epiphysis? Traction, pressure, what type of epiphysis? Very good, Dave. Ready? It is atavistic. It is atavistic. I did not give you the option purposely. That it is an atavistic type of epiphysis. It is not traction. It is not pressure. Okay. It is an atavistic. Very important question. Okay. So coracoid is an atavistic type of epiphysis. Remember that. Now the next question is, identify this muscle here. Which is this muscle here? Options are pronator, supinator, Anconeus, pronator quadratus. Is it pronator teres, pronator quadratus, Anconeus, or is it supinator? Very good. It is your Anconeus muscle. It is your Anconeus muscle. Okay. So tell me, you can obviously see in this image that Anconeus originates from where? What is the origin of Anconeus? It is not pronator. Saurabh, it is not pronator, it is Anconeus. You can see from the image, Anconeus arises from what is the origin and what is the insertion of Anconeus muscle? Very good, Dave. It originates. This is the origin. This is the origin. You can see that this bone is radius because this is the radial head. You can see this is ulna because posteriorly you can see the olecranon process growing. So this is, as you can see here as well, this is your Anconeus muscle. Okay. And this is the radius and this is the ulna. This is the radial head. So you can see that Anconeus is originating from lateral epicondyle, but it inserts on ulna. It does not insert on radius. Okay. So it goes like this. Okay. It crosses. So it comes from the lateral epicondyle. Okay. It comes from the lateral epicondyle and then it goes onto the ulna posteriorly. And what is the nerve supply of Anconeus? That is what is important. No, it is not median nerve. Yes, it is radial nerve. It is radial nerve. Okay. Very important question. Now, as we said that Anconeus is on the posterior aspect. So, posterior compartment muscles are supplied by radial nerve. Anconeus is a posterior muscle. So, it would be supplied by radial nerve. Please remember this. Do not make a mistake here. Anconeus is posteriorly. Okay. And they ask you the question which was asked previously, screwing movement. Okay. Screwing movement at the elbow or the screwing movement is basically possible due to Anconeus and it is supplied by radial nerve. Is that clear? So Anconeus image is important, lateral epicondyle, but inserting on ulna. Remember that. Now this Anconeus is supplied by radial nerve. Now tell me, this radial nerve, it gives branch to Anconeus at what level? In the axilla, in the spiral groove, below the spiral groove, or below the elbow after division. Where does it give the branch to Anconeus? At what level do you get the branch to Anconeus? The options are axilla, spiral groove, below the spiral groove, that is the lower shaft, or it is at the elbow. Okay, so I can see majority of you are answering that it is below, someone answering below spiral groove. There are mixed answers. So that is a trap here. Remember an important point, that the nerve supply to Anconeus, it comes in the spiral groove. At the level of spiral groove, you will get nerve supply to Anconeus. Okay, at the level of the spiral groove, at that level, not above, not below. Okay, and tell me, where does the radial nerve bifurcate? We know that radial nerve comes down and then it bifurcates into your deeper branch, which is the posterior interosseous nerve, because radial nerve is posteriorly, and it bifurcates into a superficial branch. So it bifurcates into posterior interosseous nerve and a superficial branch. This happens at what level? Let me see that question. Where is it? Yes, answer this question. Division of radial nerve occurs at which level? This is your NEET pattern 2015 question. A, B, C, D. Someone is answering D, some people are saying B, someone is saying D. Yes, so basically we have mixed answers here between people. You all are confused between, is it option D or is it option B? Okay, now this is a very logical question in the sense that you can use this trick in your exam also. When you're not getting the answer, integrate whatever you know. Let me tell you how do you solve this question. Now suppose I am a candidate sitting in the exam hall. I get this question in the exam and I do not know the answer, but I want to attempt this question, because the more you attempt in your NEET exam, the better you score. Okay, so let me think. So division of radial nerve occurs at which level? So what is the thinking that goes on in my brains, in my mind? Okay, now first of all, it is radial nerve. Look at the options. The options are anterior part of medial epicondyle, anterior part of lateral, posterior part of medial, or posterior part of lateral. So my thinking would be radial nerve means radial, that means it is on the lateral aspect. So I will think that probably the answer should be lateral epicondyle. Okay, so I will rule out option A, which is medial epicondyle. I will rule out option D, option C, which is medial epicondyle. So I have ruled out two options. Now I have to choose between, is it anterior part of lateral epicondyle or is it posterior part of lateral epicondyle? Okay, so this, you could have guessed it right by remembering, if you know the contents of your cubital fossa. Cubital fossa, is radial nerve a content of cubital fossa? Yes or no? Is radial nerve a content? Yes, very good, Vasudev. We know that radial nerve is a content. So you all know that it is a content. So you also know that cubital fossa is anterior or cubital fossa is posterior? Cubital fossa is anterior or posterior? Yes, it is anterior. So now you know that radial nerve is a content of the cubital fossa and it is cubital fossa is anterior. Therefore, the answer will be anterior part of lateral epicondyle, because it is there in the cubital fossa. We know that the contents of the cubital fossa from medial to lateral, it is MBBR. That is median nerve, brachial artery, biceps muscle and radial nerve. So at the two ends you have nerves, and between that BB is your brachial artery and biceps. Clear? So these are the contents, and that is how you can do logical guessing and improve your score and rank in NEET exam. Without using these tricks, trust me, it is very difficult to attempt many questions. Whatever GTs you would be giving now, use these tricks and get used to using these tricks. You cannot get these tricks accidentally, at once in the exam hall. You need to practice these tricks. That is why solving MCQs is very, very, very important. Okay. Okay, so as you can see here, this is the radial nerve which spirals at the lower shaft of humerus. This is the radius. You are even given X-ray of the elbow joint and you are asked to identify the bones. You can identify these bones by, this is the radius head, we know, the rounded one. What you see here is the ulna. You cannot see the olecranon process because it is posterior. Okay, so this is the radius, this is the ulna, and you see here the lateral epicondyle. So this is the radial nerve coming here, lateral epicondyle. Anteriorly, it is dividing into these two branches. That is the deep branch, which is the posterior interosseous nerve, and the superficial branch. Correct? So posterior interosseous nerve is a branch of radial nerve. Anterior interosseous nerve is a branch of which nerve? Yes, very good. It is a branch of median nerve, because we know in the anterior compartment comes the median nerve, so it is a branch of the median nerve. Posterior is a branch of your radial nerve. Now you have something called here arcade of Frohse. Okay, arcade of Frohse. This is related to which muscle? Heard about this term anytime? Arcade of Frohse. Which muscle is it related to? Very good Vasudev, it is supinator muscle. Okay, so this you can see here, arcade of Frohse is a fibrous band at the superficial aspect of the supinator muscle. So this can cause compression of the posterior interosseous nerve. So they can ask you these relations. First, posterior interosseous nerve related to supinator muscle by this arcade of Frohse, which can cause posterior interosseous nerve entrapment or compression. Okay, and which is the artery which is related here? What is that branch of the radial artery called as, which is related to this arcade of Frohse or posterior interosseous nerve or supinator muscle? The name of that artery or your this branch here is leash of Henry. Remember there's something called as leash of Henry. As you can see here, this is the brachial artery. This is your ulnar bone, so this becomes your ulnar artery. This is your radius bone, so this becomes your radial artery. This is your radial nerve dividing into the deeper branch posterior interosseous and into this superficial branch. And this is the radial recurrent artery. Recurrent artery from the radial artery, recurrent branch of radial artery, which is called as leash of Henry. So even that can cause, as you can see, the compression of the posterior interosseous nerve. So remember there's something called as leash of Henry again here, which can compress the posterior interosseous nerve, and it can be compressed by arcade of Frohse also. Okay, so remember arcade of Frohse and leash of Henry. You can remember this by Frohse and Henry. So if you see out of ulnar, that is U, median, that is M, and radial, that is R, the spelling of Frohse and Henry, it has R in it. Frohse is R, Henry is R. So both of them will cause compression of radial nerve, posterior interosseous nerve. Okay. So that is how the entrapment can occur at the elbow by arcade of Frohse and leash of Henry, which is a recurrent branch of radial artery. Clear? You can also see your arcade of Frohse here. This is the supinator muscle, the fibrous band superficial here, that is the arcade of Frohse, and this is the radial nerve giving the deep branch and the superficial branch. So this can cause compression. Is that clear? Yes? Now what I left here was, these are your branches of the radial nerve. Radial nerve C5, 6, 7, 8 and T1. So the root value is C5 to T1. Also median nerve has this root value. So median nerve, radial nerve both have this root value. Okay. Yes. So we mentioned already that the branch to the Anconeus is at the level of the spiral groove. Triceps is the extension, it causes extension of elbow, therefore it is supplied by the radial nerve. Then you have your brachialis muscle, brachioradialis muscle, ECRL. These are supplied above the elbow joint. That means before the division. Okay. So your ECRL, extensor carpi radialis longus, is above the division, and your extensor carpi radialis brevis, ECRB, it is below the level of the elbow. That means it comes from the posterior interosseous nerve after the division. So easy way to remember longus and brevis. Okay. So longus will have a long nerve supply. That is why it will branch off before. Brevis will have a brief or a short nerve supply. That is why it comes later afterwards. Okay. So longus will be long and brevis will be short. So that is why longus will come from the below the spiral groove in the arm itself, and below the elbow, at the level of elbow, you will have your ECRB. Clear? These are your important points to be remembered in radial nerve. Okay. And the superficial branch, it supplies the skin of the lateral dorsum of hand and 3.5 lateral fingers. We know that radial nerve is posterior, so it will supply this 3.5 lateral part of the dorsum of the hand. Okay. So let us solve some questions on this radial nerve. This is just to tell you the components of the contents of the cubital fossa, M, B, B, R. Okay, median nerve, brachial artery, biceps tendon, and radial nerve. That is why radial nerve bifurcates at anterior aspect of lateral epicondyle. Okay. Yes. Now answer this question. All are affected in low radial nerve palsy except. Yes, very good. The correct answer is A, because we said that if this is the humerus, this is your elbow joint here, ECRL will come here. Low radial nerve palsy means after the division, that means at the elbow, below that. And ECRB will be here. So if you have palsy from here, ECRL will not be affected. So remember that ECRL will not be affected, ECRB will be affected. Finger extensors, yes, will be affected. Sensation of dorsum of hand, yes, it would be affected because the superficial branch is after the division. So the correct answer is ECRL. Longus means it has a long nerve supply. Okay, so it comes in the arm itself, the distal arm. Next question. Finger drop with no wrist drop is caused by lesion of. Yes, I can see the answers coming up. Very good, guys. You are doing very good. Yes, the correct answer is B. That is posterior interosseous nerve. Okay, first of all, when you read this question, do not get confused that it is no wrist drop means that it will not be radial nerve. Okay. Whatever question you get in your exam on anatomy, try it applying on your body itself. Okay, like finger drop with no wrist drop, that means the wrist is not dropping but the fingers are dropping. Okay, so why are the fingers dropping? Because the fingers cannot be extended. And what extends the fingers? We know extension is a function of the radial nerve, so the answer has to be some radial nerve. Now look at the options. Radial nerve in the radial groove, posterior interosseous nerve, anterior interosseous nerve, or ulnar nerve. So you rule out option C, anterior interosseous nerve, because it is a branch of median nerve. You rule out ulnar nerve because you know that the answer has to be radial nerve. Posterior interosseous nerve is a branch of radial nerve. Now, but the question says there is no wrist drop, means extensor of the wrist is spared. So your ECRL, which comes before in the nerve supply, ECRL is spared. So we know that ECRL comes here. This is your elbow and there is where the division occurs. Okay. So you know that this is a low radial nerve palsy. That is why the answer is posterior interosseous nerve. Okay. So when you have a low radial nerve palsy, basically it is affecting the posterior interosseous nerve. Clear? So finger drop with no wrist drop is caused by lesion of posterior interosseous nerve. That is a branch of radial nerve itself. And we use in wrist drop cock-up splint. Clear? Yes. Answer this question now. The following muscles are supplied by radial nerve below the spiral groove except. The following, read the question very carefully. The following muscles are supplied by radial nerve below the spiral groove except. You should not get this incorrect. There seems to be a confusion between C and D. Some people say C, some people say D. See, we said that Anconeus, where does the nerve supply come from? At the level of spiral groove. At the level of spiral groove. ECRL is below the level of spiral groove. So if this is your humerus, your spiral groove here you will get Anconeus, and below that you will get ECRL, and below that you will get ECRB. Okay. So the lesion, the following muscles are supplied by radial nerve below the spiral groove. ECRL, yes. Rest of the muscles, of course, brachialis, brachioradialis. Only your Anconeus here, and above that in the axilla comes triceps. So triceps and Anconeus are up. So Anconeus is not supplied below the spiral groove. It is at the level of spiral groove. Okay. So this is the importance of solving the MCQs. Even if you know the theory, you never know how the MCQs would be framed. So the more MCQs you solve, the better it gets, it fits into your brains what questions can be asked. Okay. So Anconeus is at the level, ECRL is below the level of spiral groove. Correct? Next question. Injury to radial nerve at wrist leads to. Yes. Very good. Very good. I've got the answers. That is, answer is B. Sensory loss on dorsum of first web space. Now read the question. Injury to radial nerve at the wrist. Okay. Will it cause wrist drop? No. Because the wrist drop, the extensor ECRL, ECRB, we know the branches come here at the elbow. Paralysis of adductor pollicis. Will it be seen in radial nerve injury or which nerve injury? Paralysis of adductor pollicis. Very important. Paralysis of adductor pollicis will be seen in paralysis of which nerve? Very good, Lakshmi. Adductor pollicis is supplied by ulnar nerve. A very important MCQ in itself. So adductor pollicis is supplied by ulnar nerve and not by radial nerve. Correct? Next. Loss of supination in extended position. Yes, it supplies supinator muscle, but it comes at the elbow itself. The branch comes at the elbow. It does not come at the wrist. So remember that at the wrist there is no motor branch. No motor branch. It is only sensory. That is why it will lead to only sensory loss on dorsum of first web space. So if this is your thumb, you have the fingers here. This region which is there, the first web space, this is the autonomous zone of radial nerve, the dorsum part. Okay, very important question. They can give you an image. This area is marked and they will ask you what supplies the sensory supply here. This is the autonomous zone of radial nerve. Remember that. Similarly, in the foot, the dorsum of your first web space, very frequently asked question. What is the answer? First web space in the foot is supplied by very good, Maya, very good. So Maya had got this right first. It is deep peroneal nerve. Remember, these are very important questions that can be asked. First web space in the foot, deep peroneal nerve. In the hand, radial nerve. adductor pollicis is ulnar nerve. Is that clear? It is very important question. Image can be given. Okay. So as I said, this is the radial nerve autonomous zone. The first web space, very important. In the foot, it is your deep peroneal nerve. Remember these points, extremely important. Okay, now let me ask you about the spaces. So you have quadrangular space, then you have upper triangular space, you have lower triangular space. Radial nerve is a component of which? Radial nerve is a component of which space? Yes, it is triangular space. Very good. Very good, Ankita. To be very specific, it is your component of the radial nerve is a component of lower triangular space. Remember, it is the lower triangular space, not the upper triangular or the quadrangular space. Let me see how much do you know about the spaces. The question is, they will ask you radial nerve is a component of, axillary nerve is a component of, and circumflex scapular vessels are component of which space? We said radial nerve is lower triangular. Axillary nerve is a component of which space? Axillary nerve. Very good, Lakshmi. It is quadrangular space. And circumflex scapular, lower triangular, quadrangular or upper triangular, which space? Circumflex scapular. Circumflex, yes, it is your upper triangular. Now see, this is like very easy thing to remember, the contents and the boundaries of your spaces. Remember it by hashtag spaces. Okay, hashtag by what do I mean by hashtag? So easy way to remember, hashtag is like this. Okay, can you see that? The hashtag is like this. Visible? So you should remember this by the hashtag, the spaces of the upper limb. Okay. Now what you see here is this hand, this palm here, that is the scapula bone here. The lateral most here, this finger is humerus. And you have these two muscles coming attached to the scapula here. This is the scapula. Upper one teres minor, lower one teres major. Okay. And we said this lateral most here is the bone humerus. So that is scapula. This is humerus. And so this muscle here, you can see this muscle here, it is attaching to this humerus. So that is the triceps muscle, the long head of triceps muscle. Is this clear? Yes, can you see? Is it visible, guys? Or let me just draw it here. So I said on the lateral aspect you have scapula and on the lateral aspect you have humerus. You have two muscles coming from scapula, that is teres minor and teres major, and you have long head of triceps here. Clear? Now this is very easy once you know this. Now if I ask you what are the boundaries of your quadrangular space here? What are the boundaries of the quadrangular space? Okay, so you can very easily see the boundaries are the upper muscle teres minor, the lower muscle teres major, this lateral one shaft of humerus, and this muscle here, okay, this muscle here which is the long head of triceps. So these become the boundaries of the quadrangular space. Okay, now what would be the boundaries of this? Now if I ask you, the question is all of the following form boundaries of upper triangular space except, options are triceps, teres minor, teres major and humerus. Yes, what would be the answer to this? Upper triangular space boundaries are all except. If you do this, you will never get this answer wrong. If you are getting this incorrect, means that you have not got what did I explain. The answer will be yes, humerus. Okay, the answer will be humerus. Why? Because you can see this space here, that is your upper triangular space. This space here, that is your lower triangular space, and this is your quadrangular space. Okay, so upper triangular is this teres minor, teres major, and this muscle here, which is the long head of triceps. What will be the boundaries of the lower triangular space? What is not contributing to the boundaries of the lower triangular space here now? Options are the same. Lower triangular space, options are the same, except what will not contribute in the lower triangular space? Yes, very good. It would be teres minor. Okay, so now you've got it how to remember. So this would be teres minor, because here you see this triangle here. It would be teres major. Here you have humerus, and here you have the long head of triceps. Clear? So I hope with this you will never ever forget what are the boundaries. Just remember that minor is up, major is below. Do not make a mistake there. So minor is up, major is below, and you have humerus and you have long head of triceps. Clear? Now coming to the contents. Coming to the contents of the spaces. Now tell me if you get a question, circumflex scapular vessels are a component of which space? Even if you have not read it, you can still answer it, because circumflex scapular vessels means they will circumflex they will go around the scapula. And where is the scapula? Scapula is related to which space? Scapula is related to which space? Upper triangle. Yes, so scapula is related to upper triangle, therefore it will have circumflex scapular. So circumflex scapular would be the component of your upper triangular space. Now when you see this lower triangular space, this is your lower triangular space, that is related to the shaft of the humerus. Okay, so basically this is how it is. This end is your scapula, this is your humerus, the upper one is teres minor, the lower one is teres major, and this is your long head of triceps. So this is your upper triangular space close to scapula, circumflex scapular vessels. Now this shaft of humerus is related to lower triangular space, and we know the nerve related to the shaft of humerus is the radial nerve. That is why radial nerve will be component of the lower triangular space. Clear? So radial nerve will be related to the shaft. That is why it is the component of the lower triangular. So now what is the component of this quadrangular space? Now when you do this, you see this teres minor, teres major and humerus coming here. Where are they intersecting? Basically it is the axilla. Okay, so the quadrangular space is basically the axilla. So you will have axillary nerve, which is the component of the quadrangular space. Very important question which is asked, along with axillary nerve, what goes through the quadrangular space? Which vessels? Very good, Narendra. The question is whether it is anterior circumflex humeral or posterior circumflex humeral. You can get confused between the two. So we know that what accompanies the axillary is your posterior circumflex humeral vessels. You can also remember this by that axillary nerve is a branch of which cord? Posterior cord. Okay, it is a branch of the posterior cord. So you will have posterior circumflex humeral vessels. That means it comes posteriorly. Okay, so posterior cord, that is why posterior circumflex humeral and not anterior circumflex humeral. Along with radial nerve, what will accompany the radial nerve? Which artery? Obviously, which artery will come here along with the radial nerve? Related to shaft of humerus. Yes, Profunda brachii, that means basically your brachial artery. We all know that the artery of the arm is the brachial artery. So that will accompany the radial nerve. Radial nerve goes through the lower triangular space, and that is why your brachial artery will also go through the lower triangular space. Is this clear about the spaces? Yes? Very good. Thanks, Lakshmi. So now you can see our image here, scapula here, humerus here. Okay, this is your teres major muscle, teres minor is not shown, long head of triceps. This is your lower triangular space. This is your triangular interval or the lower triangular space which has the radial nerve, and along with the radial nerve goes the brachial artery. Okay. So remember this, radial nerve is lower triangular space, lower triangular because it is related to the lower shaft. So lower triangular is radial nerve. Along with radial nerve is your brachial artery. Correct? Yes. Answer this question now. Which is not a biological derivative of tyrosine? Yes, very good. The answer is melatonin. Melatonin is a derivative of very good. It is tryptophan. So we have already seen this in one of our sessions on Unacademy Plus also. For people who are not there, you know, it's a final call for you to join that. You will definitely benefit from the revision course that we are taking there. Okay. So remember that melatonin is TO, tryptophan is TO. So melatonin is from tryptophan, while melanin is from tyrosine. That is why if there is tyrosine metabolism disorder, there will be no melanin and therefore there will be albinism. Enzyme deficient in albinism, tyrosinase. Inheritance pattern, albinism is inherited as autosomal dominant recessive, your last year NEET exam question. Albinism is inherited as autosomal recessive. What is the chromosome? We have seen all the chromosomes in our sessions. What is the chromosome number for albinism? Very good. The chromosome number is 15, not 16. Majority of you have got it right. We know the other disease on chromosome 15 is Marfan's disease, and the inheritance pattern of Marfan's is autosomal dominant. The lens dislocation we have already seen is up and out. Fan is up and out. Okay. And what is the gene for Marfan? The gene for Marfan is fibrillin 1, not fibrillin 2. Remember, it is fibrillin 1. Clear? Yes. The family of 15. Father, mother, your fair daughter and the tall son. Please go through the session of chromosome numbers we have discussed in detail. Very important along with your MCQs. Okay. So tyrosine does form melanin. It forms dopamine. It forms epinephrine. And it also forms thyroxine, your thyroid hormones. So thyroxine is rhyming to tyrosine. So tyrosine forms thyroxine. Okay. And we have also seen this in one of our recent sessions on vitamins. In our revision course, what is the vitamin required for conversion of dopamine basically to norepinephrine? What is the vitamin required for dopamine to norepinephrine conversion? Yes, very good, vitamin C. So therefore, if there is vitamin C deficiency, that is scurvy, epinephrine not formed, that is why it will lead to irritability. So irritability is a prominent feature of scurvy. Okay, remember that. Yes, answer this question, very important question. I remember this question being asked when I was appearing for my All India PG exam, that is in the year 2012. So, and I very much remember that I made a mistake in this question because I never knew the concept of this then. But it is very conceptual question. Most sensitive abdominal X-ray view for pneumoperitoneum is. When I see this question, I can actually feel that I'm sitting in the same exam hall, All India PG. You know, some mistakes you remember forever. Yes, some people are saying D. Some people are saying A. Majority of you are saying D. D or A or C or B. See, when you get these questions where you have, very confusing options like left lateral decubitus or right lateral decubitus with a horizontal beam or with a vertical beam. So even if you know one of that, whether it is left lateral or right lateral, you can rule out the two options. So start ruling out the options. That is very, very important to score more. I am always emphasizing on this. Now the question is, it is pneumoperitoneum, means free air in the peritoneal cavity. Now what would be better for pneumoperitoneum? First of all, let us decide the side. Is it right lateral decubitus or is it left lateral decubitus? So very logical. The concept is, now there is air in the peritoneal cavity. Okay. If you do right lateral decubitus means the right side will go down. Okay, so the right side will go down, liver will go down. Where will the air come? Air will rise up. Okay, air will rise up to the left side. This is your liver here down on the right lateral decubitus. This is your air on the left side. On the left side, you already have colon and the stomach, all the gases there. So whether this is your extra intestinal, there is a free air, or whether it is colonic gas, you cannot differentiate, because black air in the colon, black air in pneumoperitoneum, you cannot differentiate. The whole principle of radiology is getting a contrast to differentiate white and black. So if you have black and black, they both look the same, you cannot differentiate. Now if you do left lateral decubitus, okay, so if you do left lateral decubitus, this is your left lateral. So this becomes your liver, this becomes your colon here. Air will now come here. Okay, air will rise to the right side. Now on the right side you have liver. Okay, now tell me that in X-ray liver looks black or does it look white? Is it black or is it white? Liver? Yes, we've all seen the X-rays where you have the diaphragm and you have the liver here. So the liver looks white. That means grey or white. And when you do this, the left lateral decubitus, the air comes here. So you have the white liver and you have the black air. So you will see the black air surrounding the liver. So this black and white will give a good contrast. Okay. So to give you an example of contrast, if you have a Negro standing in a group of, fair people of Americans, you can easily, get the odd man out, that is the Negro. But if I ask you some characteristic like differentiate or take the odd one out of that American from the group of American, it will be very difficult. Okay. Or if I ask you from the group of Negroes, that is the black, pick up one Negro which has this feature, it would be more difficult. But if I ask you to pick an American from the group of Negroes, it would be very easy, because the black Negroes and the white Americans, they would give a good contrast. So radiology is all about giving a contrast. So when you do left lateral decubitus, air comes to the right. Right means liver, white liver and black air. That gives a good contrast. So the answer is left lateral decubitus. So you have ruled out two options, right lateral decubitus. You have ruled out the second option, right lateral decubitus. Now you want to choose whether it is left lateral decubitus with horizontal beam or with vertical beam. Okay. So now the concept is, if this is a decubitus patient, okay. Now if this is a patient standing, okay, this is the patient lying and this is the patient decubitus on one side. Okay. Now this is the table where the patient is lying in the decubitus position. Vertical beam means the beam going like this. Horizontal beam means the beam going like this. Horizontal means parallel to the ground, parallel to the table. It is parallel to the ground. Now tell me logically, will you do a vertical beam or will you do a horizontal beam if you have to look at the air here, which is over the liver? The air has come here over the liver, you want to see the air. So will you do a horizontal beam or will you do a vertical beam? Yes? Yes, very good. You will do a horizontal beam. If you do a vertical beam, everything will overlap. Your liver here, your colon here down, everything will overlap. You will get like a lateral view of abdomen. So you will do a horizontal view. Remember, whenever it is a decubitus position, it is always horizontal beam. The whole purpose of doing decubitus is so that you can take an X-ray like that with the horizontal beam. So no matter whichever condition, the decubitus is with a horizontal beam. That is why the answer becomes left lateral decubitus with horizontal beam. Is that clear? Very good. Okay. Now on the same grounds, tell me which would be the most sensitive X-ray view for pleural effusion. The question is, which is the most sensitive X-ray for right pleural effusion? Options are right lateral decubitus with horizontal beam, left lateral decubitus with horizontal beam, right lateral decubitus with vertical beam, left lateral decubitus with vertical beam. Yes. What do you think would be the answer? Yes. So at least, I'm glad to see that none of you are answering option C or D. As I mentioned, if it is a decubitus, it has to be horizontal. So rule out vertical beam wale options. Okay. Now the question is whether it is right lateral decubitus or left lateral decubitus. So you are doing this decubitus view for the pleural effusion. Okay, so now suppose this is a patient standing, that is right pleural effusion. So which decubitus will you do? So when you do the right lateral decubitus, patient lying down, the fluid will gravitate down. That is how the fluid will form a layer. Okay, this is not air. You don't want, if it is air, you want to make it go up. If it is something gravitate down, it should come down. So that part should be dependent. So that is why we will do right lateral decubitus with horizontal beam. We know with decubitus it is horizontal beam. Because you want to gravitate the fluid, that is why you will do same side. If it is left pleural effusion, you will do the left lateral decubitus. If it is right pleural effusion, you will do right pleural effusion. Opposite would be for pneumothorax. Okay, because pneumothorax is air. So you want to make the air rise. So what do you do in that case? If there is right pneumothorax, do a left lateral decubitus so that the air comes up. But ideally you do not do a decubitus for pneumothorax. What is the X-ray view for pneumothorax? What is the X-ray view for pneumothorax? This is repeated many times. X-ray view for pneumothorax. Yes, of course it is a PA view or a AP view. The question is, will you prefer doing an X-ray for pneumothorax in inspiration or in expiration? Inspiration or expiration? Yes. Remember it is expiration. Remember it is expiration that you do pneumothorax. Now it is also very conceptual that why do you do an expiratory view in pneumothorax. If you understand the concept, you will never ever forget this. Now I said that radiology is all about black and white contrast. Radiology is all about black and white contrast. How does pneumothorax look on an X-ray? Pneumothorax is black or is it white? How is pneumothorax on an X-ray? Yes, air is black. We know lungs are black because of the air. That is why pneumothorax is black. Now, how do lungs look like? Lungs on inspiration, lungs on expiration. First, let us see lungs on inspiration. Will they be black or will they be white? Lungs on inspiration will be black or white? They will be black. Lungs on expiration, will they be black or white? Lungs on expiration, they would be less black or more black basically. Will they go more toward the white side or more black side? As compared to inspiration, will they be less black or more black? Yes, so basically remember that on expiration, for us to remember the concept, it would be white. Okay. Ideally, it does not become white entirely because entire air does not go out. We know there is some air, the residual volume, the ERV, which is always there. So now to remember that expiration, air goes out. That means the black part of the air in the lungs, it goes out. So the lungs become white. Now logically, of course, this gets us the concept then. So for pneumothorax, which is black, will you prefer an inspiratory X-ray or an expiratory X-ray? In inspiration, the lungs are black. In expiration, the lungs are white. So will you prefer inspiration or expiration? You will prefer an expiratory X-ray because black pneumothorax, good contrast would be given by this white lung in expiration. Okay. So the white lungs will give a good contrast to the black pneumothorax in expiration. Therefore, remember, you will do expiratory view in pneumothorax. Clear? Can you tell me some other condition where we do expiratory view? Expiratory view we said is for pneumothorax. Any other condition? Any other condition? Yes, very good. It is done for COPD or basically any obstructive cause. Any obstructive cause. Very good. Obstructive cause like foreign body. Okay. Very easy to understand this. Now we know that in your obstructive lung disease, it is the expiration which is affected. That is your FEV1 by FVC is affected the most. Expiration is affected the most. So when you do expiratory, you will see obstructive lung disease because the air will be trapped. So there is air trapping in obstructive lung disease. So even when the patient expires, exhalation, still the air is trapped. So that tells you that air trapping on expiratory view tells you that the patient has obstructive lung disease. Clear? Okay. So even on expiration, if air is not going out, means there is an obstruction somewhere. That is why the air is not going out. That is why air trapping on expiratory view. And therefore, remember that for obstructive lung disease, to look for air trapping, when we do HRCT lung, we prefer doing expiratory view also. Okay. So in HRCT, we do inspiratory and expiratory. Expiratory view is to look for air trapping. Clear? Now, if there is a foreign body, most common cause of acute breathlessness in a child is foreign body. So now this is the trachea dividing there into bronchi. This bifurcation takes place at T4. We have seen the tracheal bifurcation is at T4. We have seen many of these concepts already in our revision course sessions. Please revise each and every session. Many questions you will get in exam from there. Okay. So T4, the tracheal bifurcation. Now suppose that the foreign body is here in the left bronchus, and this foreign body is not radio-opaque, it is radiolucent. So you will not see that on X-ray because it is radiolucent. Okay. So how do you identify what is the location of the foreign body? Is it on the right side or is it on the left side? So you do an inspiratory chest X-ray, you do an expiratory chest X-ray. Inspiratory, both the lungs will be black. Expiratory, we said the air goes out. So from the right bronchus, the air will go out. So the right lung will become white. But on the left side, because of the obstruction, this side will not become white, and that is why it will remain black. Okay, because of the air trapping, this air will not go out from the left side. That is why that side lung will be still black on expiratory view. So you can compare the two lungs. Which one is white, which one is black? The side which is black tells you that this is the side of your foreign body. Okay. Of course, this was done when there was no CT scan. Nowadays, nobody waits for that. You have your bronchoscopies and CT scan, virtual bronchoscopy, which is done in CT scan. All of them help you to localize even a radiolucent foreign body very easily. Correct? Yash, initially there would be hyperinflation because of the air trapping, and then as the air gets absorbed, then you will get atelectasis. Okay, so that is why remember that your one cause which can etiology which can cause both unilateral white out hemithorax, white out lung, and unilateral hyperlucent lung. A condition which can cause both is therefore foreign body, because in the early stages, because of the air trapping, it would be hyperlucent. In the late stages, because of the air resorption, there would be atelectasis. Air is resorbed, there is no black part, means it will become white, that is white out. Clear? Arjun is asking lordotic view. Arjun, as the term says, lordotic view, you know, it is basically like an AP view itself, but as the term says, it's lordotic, means the patient has exaggerated lordosis. So we ask the patient to rest the shoulders here against the plate. So that gives a lordotic view, and you can see that in the lordotic view, you are actually trying to take this clavicles out. When you are asking the patient to rest on that posterior part, the cassette or the film, you are actually, your main mission is to take the clavicles out. So what happens in your normal AP view and what happens in your lordotic view? So if this is your AP view, you will have the clavicle overlapping the lung apex. But in your lordotic view, because of the position, this clavicle will go up. Because of the position, this clavicle will go up. So now you tell me, where will you do lordotic view? What is the advantage of doing a lordotic view? Which part of the lung will be better seen? Yes, it will be done for which part? Yes, Arjun, I am waiting for the answer. You will do that for which part? Very good. Then you will do it for apex, because you are removing the clavicles. So the apex will be very clearly seen. So basically you can do it for tuberculosis. You can do it for the apical lung tumor, that is your Pancoast tumor, which is your squamous cell carcinoma. Okay, you can do it for Pancoast tumor. Yes, you can do it very specifically for right middle lobe collapse. If they ask you that lordotic view is done for right upper lobe collapse, right middle lobe collapse, left lower lobe collapse, or left upper lobe collapse, the answer is right middle lobe collapse, because in that the position becomes like that. In the lordotic view, your X-ray beam is tangential to the pathology. So that is why the right middle lobe collapse is seen better. Okay. So remember, it is done for right middle lobe collapse and your lung apex. Clear? Now, since we are here, let me just ask you quickly, what is the investigation of choice for Pancoast tumor? What is the investigation of choice for Pancoast? Options are, let me give you options: non-contrast CT, contrast enhanced CT, non-contrast MRI, contrast enhanced MRI. What is the best out of these? Which is the investigation of choice? Sumit and Ganesh, HRCT, remember, is for lung architecture conditions like fibrosis, that is ILD, and for bronchiectasis. The two important indications of HRCT. Rest of the places you will not do HRCT generally. Is it C or is it D? Is it A or is it B? Okay. So now remember that the answer is MRI. For any space occupying lesion anywhere, you prefer doing a contrast scan. So the answer is contrast enhanced. So you rule out non-contrast, non-contrast. For any space occupying lesion anywhere, be it a brain tumor, be it a liver mass, be it a lung mass, any mass, you prefer doing a contrast scan because it helps you to delineate the borders of the mass. And Pancoast, you will prefer doing MRI. Why will you prefer doing MRI? Because MRI is better for soft tissues. It has a higher soft tissue resolution. What are the soft tissues that you want to look for? So when you have Pancoast in the lung apex, it can infiltrate the brachial plexus. Okay. So you want to look for brachial plexus invasion brachial plexus invasion, therefore you will do MRI. Is that clear? But remember that if the question is for lung cancer, it is not mentioned Pancoast. It is just mentioned lung cancer. What is the investigation of choice? The options are the same. Non-contrast CT, contrast CT, non-contrast MR, contrast MR. What will be the investigation of choice for lung cancer? HRCT I already mentioned is only for your lung architecture, basically for fibrosis, that is ILD and bronchiectasis. Any space occupying lesion anywhere, you will not do HRCT for the lung mass. Guys, I already mentioned if it is a lung cancer, that means it is a space occupying lesion. So you will do a contrast because it helps to identify the boundaries. Now the question is, will you do CT scan or MRI? You will do CT scan because there is air in the lung. Okay, so if there is a lung cancer here, it is surrounded by the air, and MRI is not good for air anytime. Air gives artifacts in MRI. So for air, we know for air the best is CT scan. That is why for lung cancer the investigation of choice is contrast enhanced CT. Okay, but what is the gold standard for lung cancer? Now the question is gold standard. What is the gold standard? I've already mentioned, discussed what do you mean by investigation of choice, what do you mean by gold standard. So you should be able to answer. We have discussed this in one of our revision course sessions. Very good. It would be biopsy. Okay. So gold standard is something which is invasive, but it is a foolproof technique. It will give you the answer, and the invasive technique which is very definitive is biopsy. Which biopsy will be preferred? Ultrasound guided, CT guided or MR guided? Which biopsy, or an open biopsy? Which biopsy? Ultrasound, CT, MR or open biopsy? What will be preferred? Yes, CT guided, because lung contains air. So for air it is CT scan. So we will prefer doing a CT guided biopsy. For liver lesions you can do ultrasound guided biopsy because liver is seen very well on ultrasound. Okay. So the gold standard is biopsy. What is the investigation for staging? For staging of lung cancer, what would be the investigation? Investigation for staging? For staging, what do we do? Very good, Shreya. For any cancer staging, we do PET CT. Why PET? Because it scans the whole body in one scan. So you can look the primary cancer also, plus you can look for the metastasis in the entire body also. We have already discussed your important nuclear scans and the PET scans, DOTA PET, DOPA PET, your SRS and thallium subtraction scan. We have discussed all of those. Please revise that from that session. We have already discussed. In PET we use F18, the half-life is 110 minutes, technetium used in scintigraphy, half-life is 6 hours. We have discussed the half-life of other radioisotopes. Okay, so this was just to give you an overview. How do you decide the investigation of choice, the gold standard for any condition? Is that clear? Okay, so I think guys, that's all for today. We never realized that it's already more than 1 hour that we have, communicated, interacted. It was a wonderful session. Yes, so that's all for today. I will see you today evening 5 p.m. in the course, okay, at Unacademy Plus, the revision course which I am taking, with very similar high yielding topics. Yesterday we had seen the various scorings, the trauma scorings and the liver scorings, the child score, MELD, PLD. We will see very similar high yielding topics in our plus course today at 5 p.m. from 5 to 6:30 p.m. Okay. Tomorrow also maybe I will have one session on YouTube. Stay connected with me on the social media platforms. I will update you whenever I come up with other sessions as well. Okay. And that's all for today, guys. Thanks a ton. Happy studying. Keep revising and keep winning. Signing off for today. Till the evening, I'll see you at 5 p.m. Unacademy Plus. For people who have not subscribed, you can see me today at 5 p.m. by subscribing at Unacademy Plus. You know, we have the final call offer which is going on. So make the best use of that. You can get subscription for 1 month at 1499. You can use my referral code Dr. Nikita. In case of any queries of subscription or how to access, you can get back to the Unacademy team at the intercom or the chat option. They would be ready to help you. So thank you and best wishes. Keep studying, keep revising and keep winning.